Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Hello, everyone. Today, I'm thrilled to welcome Dr. Mary Warren. She's a leading expert in the field of visual deficits and hemianopia in adults with acquired brain injury. We're going to explore the fascinating topic, unpacking some of the latest research and sharing practical insights you can start using right away. Welcome, Mary.
Thank you, JJ. I'm glad to be here.
I can't tell you, I've heard so many incredible things about you from my OT colleagues. They're like, you've got to go to that course. You've got to go to that course. So I am, and I've tried, but I just never works out with my schedule. And I am beyond excited to have you join us today. So that I can get to know you a little bit and everybody listening. To kick things off, could you tell us a little bit more about yourself?
Yeah. I am in Kansas now, and I am from Kansas. So I'm a graduate of the University of Kansas way back in 1976. And I have a master's degree from Kansas, but I got my PhD at the University of Alabama at Birmingham.
Oh, nice.
Where I was recruited to teach, to develop an online program for low vision rehab, which included neuro in it. And so most of my writing and a lot of things that I've done, I did while I was teaching. I taught for 17 years at UAB. And then in 2018, we retired and moved back to Kansas because that's where everybody lives. We wanted to be back with family. And I was teaching a lot of courses at that point. And I think that's how people really know me. And I thought I would do that forever, but the pandemic came along. So I haven't taught a course since then. That's been a live course. But I did move to online teaching. Craig and I created a little course, a little company, a mom and pop company, courses.visibility.com, where what I've done or am doing is taking my lectures that I taught to people in workshops and putting them into online courses. So that's what I'm doing these days. That's my academic or my professional contribution to everything right now is creating those courses.
Well, then I consider ourselves very lucky to have gotten you here. I know your area specialty is vision, and so I'm really curious about what sparked your interest in that area and where your passion came from for that.
Yeah. To me, it's just a classic scenario. I graduated in 1976 from a good school, but in my undergraduate education, I was never taught anything about vision. A client could have low acuity, they could have a hemianopsia or a hemianopia. You can use either term, but nothing about it. So I get into the clinic and I'm seeing clients who I think have vision problems. I go and I talk to the senior therapist and no, we never see a vision problem. And I was just curious about it because I felt like I was seeing it. So I started to investigate it. I did what we're supposed to do. I looked at literature. I got out textbooks. I read about it and kind of schooled myself on it. Where I really became interested in it is we decided to start a driving program. And I volunteered to do that. We were the only program in eastern Kansas and western Missouri, and we had a huge base to draw our clients from. And most of our clients had brain injuries and wanted to resume driving, and they could drive in Kansas with a field deficit, but they couldn't in Missouri. So I had to figure out how to really evaluate this area And would it affect driving? How would it affect driving, and those types of things? And from there, I just started looking at everything.
I love that, because really that's just a great reminder to all of us. It's just that you don't know the answer, so you're just curious, and
That's
you're
right.
searching, and then you ask questions, and then another why, and more curious, and especially driving. Gosh, that's so important to people. So to try to explore that for them is just really amazing. So I love that, and not for nothing, but I'm really excited that you said hemianopia or hemianopsia, because I can say hemianopsia better without getting my tongue tied. So I might say that as long as everyone knows. It's either one.
Telling you, JJ, the vogue is hemianopia. That's where it is now, but you'll find lots of references to hemianopsia, and it's the same thing.
Okay, good. Yes. All right, so that's good. So when we think about, I'll try to do it, but hemianopia, I guess I should practice and be better. But why is it so critical for clinicians to understand that? And really, then you can maybe progress to what are some of the key challenges that individuals with this condition face in their recovery and their daily lives.
Okay. It's really important because it's common. It is the most common visual impairment you will see if you work with a person with acquired brain injury. And when I say acquired brain injury, it can include anything, but mostly the research is on traumatic brain injury and stroke. So you're going to see it. You're more likely to see it than anything else in your practice. The other thing that's unique about it, though, is that it creates a permanent visual deficit. There's very little chance that the client will recover their vision once they've experienced this kind of condition. And it is the only condition that Medicare considers to be a low vision condition. That's why you'll see it treated a lot of times in low vision rehab programs, because it is permanent. So it creates a permanent deficit. The person has to learn to live with it. It affects two really important aspects of our daily lives. It will affect reading, and it will affect mobility. And so the client will have difficulty, not that they can't read. It's not a language deficit, it's a visual deficit, but that the reading becomes very tedious and very slow, and it's just hard to read. Their mobility, because they're missing vision in one half of their visual field, often they have difficulty safely navigating places, and they have a tendency to get lost and that type of thing. I think I need to kind of back up a second about this. A key to understanding visual field deficits, all types of visual field deficits, but hemianopia in particular, is that you lose half of your vision when you have hemianopia. Hemi means one half, and means without, and opia means vision. So you lose half of your vision, usually on the right or left side. And even though you have lost half of your vision and you are blind on that side, the brain perceptually completes the information on that side because it's just a natural way we process vision. Our prefrontal lobes, when we're looking around our environment, sample the environment and predict what's going to be in it. So it's not really a visual thing that you're doing when you're looking around your environment. It's using just sampled visual input to create an environment for you. The prefrontal lobes do this because that gives us a lot of speed and flexibility in our visual processing, and we can do great things like drive, for example. But it's a problem. Perceptual completion is completely normal, but it's a problem for the client with hemianopia because they're blind in one half of their visual field. But the brain is not, or the person is not alerted to this blindness. For them, when they wake up with a hemianopia, they see the entire field, but they have a false image of what is occurring on the blind side because the brain can't predict what it's not seeing over there. It can't fill it in. And that false field for them makes it very difficult for them to figure out what's going on. when they first develop hemianopia. It's very hard on them when they're trying to navigate a very dynamic environment where things are changing and moving. It affects a little window that the brain uses in order to read. It's called a perceptual span. It chops it off on the side of the hemianopia. And they just end up with a lot of problems.
Can I just,
Yes.
just make sure I understand this.
Do that and I'll take a drink here.
Yeah. So what you're saying from the hemianopia is that, okay, so you've lost a visual field component, but your brain is filling that space in, kind of like AI might fill in something, but it can't predict the movement. And so when people are moving through Enforce, they think that they see everything, but they're missing
and they don't
components.
Yeah,
Is that accurate?
That's accurate. You're good. You're good at this. You got it. Now and what it does is it obscures the border. Like if I had an actual black curtain come to in my vision, I would know to look around it. I would know to turn my head and see what's over there. But because a person doesn't have it and because they get a lot of false information in there, they just make a lot of mistakes. They run into people, they bump into objects, or, they get disoriented and they can't quite figure out what's going on with their vision. They just know basically that they can't trust their vision because this is occurring. And what we see and what really bothers me as an occupational therapist is that they start avoiding the activities that really put a lot of demand on their vision. They drop out occupations. They're good on their basic ADLs, but what really takes a hit are those instrumental ADLs, and especially something that's going to occur in a dynamic environment, the community environment. They retreat to their home because they know their home and they know where everything is, and it's a more static environment. And so they don't like to leave their home to do things, and they also don't want people to come into the house and mess things up. So they might not want their grandchildren over there anymore, other things. But it really restricts the person's social participation. They lose a lot of those activities that are fun to do. We do our basic ADLs, but they're not the thing that give us joy in life, right? And you just lose all those things. And then you can be confined to your house. So the other thing about hemianopia is it causes a great deal of depression in this population. So it can be very debilitating.
I really appreciate, I don't know that I've ever really looked at that from a big picture standpoint. I mean, tend to look at, okay, the ADLs and, okay, we're going to teach the strategy, but kind of taking a step back and saying, wow, I mean, that was a lot that you just said that I think is really insightful and good for us to remember so that we can think bigger when you come later to treatments. But before we do that, I think, can you help us out in regards to neglect? Versus unilateral spatial neglect versus hemianopia?
Good question. I'm glad you brought it up. Hemianopia is a vision impairment, flat out. You've lost vision. Neglect is an attentional impairment. Okay, so they can occur together, but they don't have to. They can be different. They can be separate from one another. That's what I want to say. So you can have neglect that also involves hemianopia, or you can just have hemianopia, or you can just have neglect. But the key difference is the attentional component versus the visual component. Persons who have hemianopia, because they don't typically have an attention impairment, okay, they may, but they typically don't, can use their attention to compensate for their vision loss. Persons who have neglect, because their attention is affected, often can't compensate as well. On a surface level, these two, particularly in the early stages of recovery, they can look the same. And it's very easy for therapists to look at somebody, or a physician to look at somebody and say, well, they're neglecting, when really they may just have a hemianopia.
I think that's a really good point. I think that we tend to go neglect first because it is, I mean, it's a little challenging to tease out in the beginning when their function is a little bit lower and their cognition, because now you're mixing in, is it cognition or is it that they can't, attend, or is it, and then do you see that hemianopia being missed later? Like as they progress, people didn't think it was that, so they didn't explore it more? I don't know. It's just.
Yeah, exactly. That's what happens. I worked a long time in inpatient rehab, but for most of my clinical career, and I always had a clinical career, even when I was teaching, I was in a low vision clinic working, is that we would get clients who had been through all of their rehab, and then they figured out that they had a visual field deficit. And oftentimes it came when they were trying to resume driving, and they couldn't resume driving because they weren't fast enough in picking up information on that side. So it's very easy to miss. We always had an old joke, is that we worked really hard to get physicians aware about hemianopia, and then every client we had hemianopia, and then we worked really hard on them to learn about neglect, and then every client had neglect. Right? You can't always rely on the physician because they're not spending much time with the client.
Yeah.
You see the behaviors that they have that tell us there's a vision impairment there.
But I think you have a good point. I mean, even you go to a course and you come back and you're like, there and there and there and there.
Yeah.
And to make sure that we're continuing to be curious and recognizing,
yes,
okay, this still could be, and to, when things don't make sense, like, oh, they're acting different, that doesn't make sense.
Yeah.
To follow through with that. So, I mean, given what you just said, are there key questions like the clinicians should be asking so that they can kind of determine that and address it?
There are not so much key questions. Well, there's one key question that really is important that will help the therapist. And that's the question is, where is the damage in the brain? Where did the injury occur? If it is occurring in the occipital lobe, you can guarantee there's a hemianopia or something else going on. There's a field deficit in there if it's in the occipital lobe. If it's in the posterior areas of the brain, then there's a really good chance that the person may have a visual field deficit associated with that. So asking that question is important. Where did it happen? But other than that, it really is kind of a set of observations that you see. These clients have very specific behaviors that they use in order to compensate. Like if you're asking the client to walk down a corridor or, across a clinic or something, they will walk very slowly. They will often stare straight ahead. It looks odd. It's like they fixate on something, the target that they're going to walk to, and they walk to it. But you don't see this spontaneous awareness of either side as they go. When they're really struggling with their vision, they tend to shoegaze. Shoegaze is when you look down at your feet and follow your feet as you're walking. They tend to get close to things. They might not necessarily bump into them, but they get very close to things. And they look stressed. It's very easy to see the stress on their face. They're very uncomfortable in what they're doing. They may put their hands out to guide themselves around. So if you're aware that those are the things that are hallmarks for hemianopia when a person is walking, you look for those. When we're talking about reading, they cut off either the beginnings or endings of words depending on whether or not they have a right hemianopia or a left hemianopia. They can't navigate text. They lose their place on text. But it's not a language issue because they can identify words. They can figure it out. They just visually have such a small window to read through now that they can't move quickly. If the hemianopia is on the same side as their dominant hand, so like I'm left-handed, if I had a left hemianopia and you asked me to do something that was very fine motor, I had to really watch my hand when I was doing it, like typing on my phone or putting toothpaste on a toothbrush, those types of things where I really need to be looking. I won't be able to do it very well because I can't see what my hand is doing. It affects handwriting. Handwriting legibility goes down, but it's a visual issue again. It's not a cognitive issue. Motor problems, like if the person has to place their foot very specifically, like they're going up a step or down a step and foot placement is important, they often have to really turn their head and look down to try to figure out where their foot is. So it affects a lot of different activities. And if you know that these are the things that are going to happen, then you can look for those behaviors. Behavioral checklists are probably the most useful assessment that we have. We just don't have, I have a lot of them as part of the brain injury visual assessment battery for adults, and that's posted on our website, and you can download that and use those checklists and use those assessments. But in looking at the research on this, there's one test that's out there now called a flash test, where what this research group has tried to do is sort of look at the behaviors that indicate hemianopia. And they've done enough study where they've sort of identified the key behaviors and then compared. They first looked at patients by their behavior and then followed up with a visual field analyzer to identify the true deficit. And they found good results. So you can't go out and find their form yet. They haven't published it or anything, but they're in the first stages of that research. And I was very excited when I saw it because that's the direction we have to go when we're observing for vision deficit.
Okay, so you just said a lot, and I'm just very excited.
I did.
Sorry, you'll get used to me. So the flash test, that's just something to keep our eye on. Is that what it's called, the flash?
It's called the flash test, and just follow the literature, pay attention. And eventually, I think they'll get it into practice.
Beautiful. And so all of these little things, the observation is so, so important, and I wholeheartedly agree with you. Could they be presenting where someone might assume they're more ataxic because their hand or their foot isn't going where you want it? And so then we kind of play the ataxia card. Yeah. I don't mean that in a bad way. I'm just meaning, they can't place it where they want to. Yeah. So assume it's ataxia. Then I always say be careful because you don't know if you didn't clear vision. Like if you're just going to go hardcore, just going to walk them, go hard, and then it'll come. But if you didn't address the actual problem.
That's perfect. That's perfect, JJ. That's my bottom line, is that you should assume if the client had a posterior injury to the brain, that they have the deficit, and you should be looking for it. Because sure, it could look like a client is not coordinated or has a sensory impairment in their leg or something. I mean, it can shoot you off into so many directions when this condition is very, very common and is very likely to be occurring in the client. So assuming that they have it, looking for the characteristics of it, distinguishing it from neglect, knowing that neglect is attention and hemianopia is vision, helps you figure out the best approach to a client.
And it's okay. That's exciting. I mean, it's OTPT together, right? Because I consider my observations pretty good, but sometimes if I think, that's ataxia, then I start going down a road where I feel, okay, this is going to take longer, and I need to try this and that. And then it's like, well, that worked, but it wasn't supposed to. So that's weird.
Yeah.
So when I hear myself say, that's weird, that's when I would go to my OT and say, can you look at their vision? Like their eyes. I love that shoe gazing. I don't think I've ever heard that before. Shoe gazing.
Well, you'll see it all the time.
I mean, I would say, they're looking down the floor, but I mean, I don't know. I just really liked that because again, they're pinpointing a spot. So I love that. So more observations. And then if things aren't aligning, it's just because it's the brain. So it gets so complicated. We get frustrated, and to have more options of, did I check this? Or did I check with OT about what they found or speech or whatever?
Well, and I like what you say about a team effort, because it really is a team effort. Nursing is going to see it differently. PT will see it differently. OT will see it differently. Speech will see it differently. Everybody needs to sit in the same room and say, this is what I see, this is what I see, and then think, okay, is it all seem to be occurring on the same side? So it's left side or it's right side. and work from there. The assessments that diagnose a hemianopia are difficult to take. They require a great deal of attention, use a specialized piece of equipment. You have to go off-site. It's going to be in an ophthalmologist or optometrist office. And so you're not going to have somebody to be able to just come in and diagnose it. Now, a physician may look at the injury in the brain and say, I'm pretty sure they've got to have this, and that will help. But you're not going to get a good diagnosis right away, and you're not going to have a screening tool that will define it, definitely. So you have to assume it's there, work together, and then provide the interventions and see if the client gets better as they're recovering.
So, okay, so that's great. So speaking of interventions, since you brought that up, and I'm just thinking, I'm picturing this team sitting together and saying, okay, we know, I like what you said, and it's just a reminder, so I say it out loud to myself, is, okay, where in the part of the brain is the injury, so that we can assume, so that we can incorporate this. And then, what do you see that's working so that we can be consistent with that? So just to get us started with figuring out what's working for this patient, what have you seen in the current research that helps us with effective interventions? What strategies could we start with and then make sure we're communicating?
Yeah. When you look at intervention for this condition, number one, there are attempts to restore vision. There's a lot of research that has tried a lot of different ways to just restore vision to the hemianopic side. And basically, the conclusion at this point is that you can't. There's no way to stimulate it to get more recovery. Lots of research, but nobody has gotten the cure yet. Okay, so that's the first thing. Don't think you're going to get their vision back for them. The second thing is to realize that environment significantly affects this client. It significantly affects all clients who have vision impairment. But when you have a hemianopia, if you have a lot of visual stressors in your environment, visual stressors include things like poor contrast and a lot of glare and not enough light and a lot of pattern and a lot of clutter, those types of things. A client who has a hemianopia or any other serious vision problem can't function in an environment like that, and they'll shut down, they'll have problems, they'll refuse to participate. So what you can do is first of all, modify the environment, take out those stressors, make sure you have good lighting and the lighting isn't bothering the client, make sure that things are not cluttered, make sure the pattern is low, make sure the environment is structured, and see how they participate in that environment when you do those things. The only real intervention technique that's related to performance skill that has any kind of research behind it and evidence base is compensatory visual scanning. But compensatory visual scanning has a lot. And so there was a Cochrane review done in 2019 looking at interventions for hemianopias, and it was the only one that had enough evidence, but it rose almost to a level. Do they call those standards when you get to the highest level? Can't remember right now, but it came up well. And so it's recommended that you always use it. Well, compensatory visual scanning on a basic level is that you teach the client to turn their head. Okay? So we're not used to turning our heads. We don't have to. We have full visual fields. We don't need to turn our head much. But if you have a hemianopia, you need to turn your head a lot, way wider than you ever thought you had to. And you have to be consistent in doing it. And you have to be aware of the things that are on your hemianopic side that are going to get you in trouble, and look for those things as you navigate environments. So compensatory visual scanning training has been proven to be successful. The other thing we have to remember about training, though, is that it's very task specific. That's what the research shows as well. So, I can't use compensatory visual scanning where they're turning their head widely and they're They're seeing their environment. I can't use that for reading. That's not going to improve reading performance. That's going to improve mobility and navigation and IADLs and that type of thing. But reading, it has to be done very specifically to improve the person's ability to move a smaller perceptual span through reading text. So it's something that the OT would work with the speech pathologist to figure out that reading piece. So it's task-specific. Compensatory visual scanning is the only approach that really has a lot of evidence behind it.
Okay, so maybe in a few minutes, maybe you could give us, right, I think we have some specific examples, or at least that we could brainstorm together in regards to how you've incorporated for people, because I just think, okay, I didn't realize like this isn't going to get better. And just that impact has had a significant impact on me right now. And then thinking, I'm all about the task specific, but this is even more important because the habit.
Yeah.
Like you're saying, you're 60 years old and this happens to you, you have 60 years of habit. And so that you're forming new pathways to try to form a new habit that really isn't ingrained. And that's not an easy thing to do. We have to go big to make sure that we're getting everybody doing it and finding small ways to make changes in their home and those types of things. So, I'm interested when we get there of things that you're thinking that is beneficial for that, because that is, wow, that's kind of just hit me a little bit hard. So, but, when you look at the conditions, I think you kind of brought this up, but there's certain patients or conditions that are most appropriate. Essentially, it's just anyone with that kind of injury to their brain.
Yeah.
Right?
Yeah, because a good case of encephalitis could do it. It doesn't have
I didn't think of that.
A brain tumor, other things like that. It doesn't, we are going to mostly see stroke and traumatic head injury because those are our big populations. But any condition that can injure the posterior area of the brain can cause field deficit.
Okay, beautiful. So just so that way, again, I think I appreciate you bringing up more diagnoses just so that we're keeping this in mind when we're looking big picture at our patients. So if you're looking at clinicians incorporating assessment and treatment, because I know you said really from an assessment perspective, there isn't any great test. You've talked about some things. Can you kind of summarize from an exam perspective, and then we can talk about more intervention components?
Yeah. I think from an evaluation standpoint is, first of all, look for it. Okay, use your checklist, and as you're observing the client do ADLs and other activities, observe for consistent patterns of behavior that would suggest that there is a hemianopia. Then answer the question, is it neglect or is it hemianopia or is it possibly both? And we have the Catherine Bergago scale, which is used a lot to look at neglect, and a very good scale with good research behind it. Clients who have hemianopia will not look like that. They will not show that same set of behaviors that we see on the Catherine Bergago. So the Catherine Bergago is a good...
Everyone will remember it now. Catherine Bergago is a good assessment. Neglect, right?
Yeah, and you can do that. It's an ADL observation, and you can do that same kind of thing. And then I think you experiment with things, because like if I create a better environment for my client, a client that matches their skills much better, then they're going to perform better in that client, in that environment that I've created for them. So if I'm adding more light and I'm decreasing pattern and I'm reducing contrast and I see an improvement in behavior, quite frankly, a client with neglect will improve as well if you give them a good environment, but the client with hemianopia will really improve. If I start teaching compensatory visual scanning and I tell the client, if you're missing something and you seem to always miss it on the left side, I want you to do this. I want you to turn your head really widely. And we need to establish that as a habit, as something that you do. And the client really improves when you do that. because they're able to use their attentional system, to establish that habit, then you know that you have hemianopia more than you have neglect or anything else, because they really vary there. So you can start to modify the environment, begin the compensatory training, see how the client responds to it, and you'll get a good feel for it as you move along as whether or not this client is really being affected by their attentional deficits and they have neglect, which is compounded by the hemianopia, or if they just really have a deep hemianopia and they need to learn to compensate for it. Now, I've prattled on so long, I can't remember.
No, that's okay, because I'm just going to say, you reminded me of something I wanted to say earlier, or just reinforce that the setup of the environment.
Yes.
Like you're saying, what a big impact. And you're in a busy inpatient rehab setting, and there's all these things going on, and we're trying to make things creative for other patients, and, there's not a lot of space. I just think we forget sometimes, because I'm just going to speak for PT, I might just be walking, but OT's walking them as well. And, you're going in between. I think for me, this is just so helpful. It's not like I didn't know these things. Like I didn't know this definition and this definition. I did. But I think that this bigger picture and being more intentional with trying different environments, because we have this background thought and we're observing certain things. I don't know what's going on yet, and that's okay. Just want to say it's okay if we don't know what's going on. But then to try, I just liked your examples of the environment and increasing the light and decreasing. I mean, we think of distraction from an attention standpoint, but it does decrease that visual component. So I just think, I just wanted to reiterate that, because I think that's a strategy that, a therapist can kind of grab onto and to really compare, because then you could document, you utilized this type of environment and these were your outcomes, as opposed to just assuming. And then the next day they didn't do as well, and not noting that it was a different environment and just thinking, oh, well, they're tired. There's a lot of assumptions that are made because we're just really busy.
Yeah, well, and I think, and you've got it, we tend to think, well, observational evaluation, that's not very good. Give me a test. I need a score. I need all of those things.
Yeah.
But in terms of the client and what you're doing with the client, improving their ability to move about their environment, it is important, because as you change things, those behaviors, that looking at the floor, that's weird, staring ahead, that kind of difficult pattern in walking, that resistance to going outdoors or into a crowded environment, that panicked feeling. That's the other thing about these clients, is they can actually get a panic attack when they're forced into a very busy environment. Their brain is telling them, you need to get out of here, and I'm going to make it really hard for you to stay. So you're going to get upset, and you're going to start breathing heavily, and you're going to sweat profusely until you leave. That's the panic attack that can occur. When we are modifying these things and we see those behaviors decline, and we see the client willing to go with the family on a family outing and not pushing back on it, not resistant, and moving more quickly and more happier. We see these outcomes. We can identify these outcomes. We can quantify these outcomes. It's just that we don't have a little test that gives them a score. So it really is a very hands-on approach to rehab. That's why
oh my gosh. So, okay, I'm sorry. My head's exploding, because I'm thinking about, first I was thinking, oh my gosh, it must be so scary, because I'm imagining myself and all, and then things kind of come out, and I'm a startle person anyway. So I startle really easily. And so just that would be so fearful. And then I think about, okay, I push therapists, make sure you do the ABC scale, make sure we're assessing fear of falling, because I'm trying to determine a trend of what's fearful. But I haven't taken as much as I'd like to now, the look of the vision component of the fear, the direct relation of how it could be that related to fear of falling versus okay, well, they're scared of falling. Well, what does that mean? And how can we explore it more?
Yes.
This would be interesting once they have the observational checklist, like tying it to an ABC scale or something.
Yes.
From a fear of falling standpoint.
Yeah. Oh, yeah. Fear of falling is a huge, huge issue. And you do have an increased chance of falling when you have a vision deficit. And so the person has fallen or come close to falling, and there is a lot of fear there. But it's intangible in the sense that when I worked with clients and I worked with them over a period of time, we would see them for about 8 treatment sessions, but we would go from just work in the clinic all the way out to shopping for groceries and then on to a driving referral. That's how far we could take them. You see that person start to come back into their own. You see them joking around. You see them taking control of their environment, pointing out poor environments. You should do something about those steps, and and that type of thing. Critiquing your therapy environment, you see them start to come back, to the person that they were before. And families report the same thing, that the person now, instead of resisting going to the grocery store, or resisting going to church, or wanting to stay in one room of the house and, always in a bad mood and always irritable, that they're starting to do things. They're just getting back to their old habits because they understand how to navigate an environment.
I love the idea of them critiquing. It's kind of like facilitating autonomy, right? Giving them control.
Yes.
And putting that in there. So this scenario that you just pictured, or you just gave us a picture of, in regards to them resisting this and resisting that, and people, they're non-compliant, or they're this, or they're, how do you approach like communicating with the caregivers and care providers about what you just said to me? Like, how do you explain, like, they're not just being resistant for the sake of being, resistant?
I think the important conversation to have with the caregiver is first that they understand that this is permanent and it will probably not get better, so that they're not just waiting for their vision to improve and tolerating behaviors and allowing all that resistance to occur because they just think, oh, I'll be gone in a year, it could get better, because it's not likely to get better. And then we help the family understand that if they create an environment that supports the person, they will do more. Okay, so we go through all of the pattern, home visits are really important. We go through how much light is here, how much pattern is here, how much contrast is here, how much clutter is here. And you all have been in homes. There can be a tremendous amount of clutter and low contrast and glare in environments. So it's important to try to make a home environment, and best if the team does it, because PT's perspective is going to be different than OT's. And then you give them a couple of strategies. And one of the most important strategies that we teach the family and the person themselves is that when they come into a new environment, so let's say they're coming into the grocery store it's been a long time. They're coming into the grocery store. What they need to do is they need to stop before they go into that environment and purposefully turn their head from side to side and catalog what's there. They need to look, is there a temporary flower stand right here that I might bump into? Is there a shopping cart left over here? Just look at it, purposefully look at it. Client can do it with the family member, and then start to move through, because once you have built that environment in your mind, and that's the problem with hemianopia, is they don't build a complete environment. But if you do your compensation and you build that environment, then you'll feel more comfortable moving through it. And then getting them out and taking them places, but not forcing them to move real quickly to begin with. You have to be patient. You have to allow the person to navigate it. You can't pull them through an environment. You just have to have those types of things until the person gets familiar with the environment again. and to start with the things that are really familiar to the person that tend to be more static, like going to church. If that was a routine, then you can go to church earlier than everybody else is coming. You don't have to be a last minute person. You can get there. You can find your pew. You can sit there. You can wait until other people exit and then exit. So you're just easing them back into a situation where they will feel comfortable with it again. The more you do it, the better it is. And some of these horrible kind of fear-based things that they feel, the increase in their pulse and their blood pressure going up and their sense of dread, go away for the person, and they're willing to do it again. It just takes time, but it really takes a lot of understanding from the family and not allowing them to just stay in their own homes.
I love that. And I love specific strategies. And I think, I think the PTs and OTs I'll speak for myself. I can learn a lot about, because I don't think I ever had them do the scan before I walked with them. Like, I'd work on head turns, but I wasn't being purposeful in regards to, okay, we're going to stand here first and I'm going to reinforce these concepts for when they go home, that you're going to scan this whole gym and scan it again and kind of close your eyes, picture it. Let's, and now let's incorporate that and let's slow it down and not just be focused on speed for intensity, which is important, but let's do this first and then progress to that, because that's one of your primaries. So I think that's really helpful. And so you kind of mentioned some of these actionable takeaways now, but can you just recap your top 3 actionable takeaways that you would give for clinicians to really maximize that impact on the treatment with the patient with hemianopia?
I'm going to sound like kind of a broken record, but it's first assume it's there. Look for it. I guess is what I'm saying. Look for it. And we were taught, in school to link the area of damage in the brain to what was changing in the body. And sometimes we don't realize that that's really important for us to stand back and do that. So first, look for that. Second, consider the environments that you're putting the person in, and realizing that you are either helping them or you're making it harder for them to use their vision. Use compensatory visual scanning training. Really concentrate on the things that give a person joy in their life and motivation, because the dropping out of occupation is the big issue with this client group. They stop doing those things. And depression is on the other side of that. And we want to ensure that we are getting them back in their environment in a supportive way that they can improve. And I have to give a shout out before I finish this, is that I learned probably the most about how to work with a client in these environments when I went into working with clients who had low vision from macular degeneration, and I came in contact with certified mobility specialists and people who've always worked with somebody who had a permanent vision deficit. And they've been very generous in kind of sharing their knowledge of how you work with somebody in an environment with us. So there's no claim that we invented this, but we brought another member into our group and learned a lot from them. And it's important to have that teamwork. And, if you're struggling with the client, you can't go anywhere with them. And there is a comms in your community, a certified mobility specialist, or that person is a veteran and entitled to those types of services, then refer them on to someone who will take them out and work with them.
It's all about sharing information.
It is.
I really love the podcast so much because, it's just sharing all these brilliant people and you've gotten information from other people just like I have, just like we all have. So it's all sharing it and making it better and then sharing it some more for the people that we work with. Now, we only have a couple minutes left because Oh, that was so great. I'm just wondering if you have like a practical case scenario, like you could just walk us through. I know that you've talked, I know you feel like repeating yourself, but someone's jump out in your head that you could talk us through what you did for them specifically that was a little different.
Okay. I won't name names, but I'll talk about one of the last clients that I worked with before I had to retire. And she had come in to the clinic, and you could just see the depression on her face. And she moved so slowly, and she was just kind of beaten down about it. And so I started to evaluate her. Now I'm working in a low vision clinic, so I know she has a hemianopia. She has seen the doctor. There's the diagnosis there. I'm not figuring it out. But I start talking to her about, I bet you are experiencing difficulty with this. I bet you are experiencing difficulty with this. I bet this is a problem with it. And she's looking at me like, finally, he gets me. And I start saying, you don't have, we can change a lot of these things. And over a period of time, I'm going to teach you how to use your vision much more efficiently. You may never get the rest of it back, but you won't miss it. By the time we're done, you'll be doing those things that you want to do. And you may even be able to resume driving. Driving's more complex, but we're not going to rule it out as a goal. And to just watch her change as we went through those weeks, my last weeks with her, I would say she was getting much better in her mobility in the clinic and feeling more confident. And I said, okay, now here's the test. What you have to do is you have to let one of your sons drop you off in front of your store. Pick a small one, drugstore, someplace that you know, and you go inside and you find one item that grocery out of that store and come back. And she did it, and she's like, I did that, and then I did this, and then I did this, because the understanding that they can get out and they'll be okay and they can find these things is just empowering to the person. It's addictive to the therapist as well. When you get a client who is just, taking control of vision. The last thing I'll mention on her, because I love the story, was that she kept losing her phone. And I said, well, you look at your phone, it's got a black case. It probably just blends into the background, and that's why you lose it. I said, just get a brighter case and you'll probably find it more. So she did. She went to a dollar store. She bought a bright pink case. She bejeweled it with nice things and brought it back to me the next week and was just like, I've got it. I haven't lost it since. And I said, there's so much more, so many more things that you can do.
I love that story. I need you to say it again, though, because I just think this is so important. You said, and the way you said it, no, I can't remember, but it was that, you're not going to get that back. And once we hear that, I think people then feel, okay, well, then what's the point? But you said you won't miss it. How did you say that?
You won't miss it. If you live with it long enough and you really compensate for it, and we can take you to driving and other things, it's an annoyance, like a limp is an annoyance, or, having to sit down because your legs, those are annoyances in life, but they don't stop you from living your life. And you can get to that point. You can have it all back. You just are going to be doing it in a different way. And so be coachable, accept my advice, get out there and try it. But I really think what gets the client to try it is when we say, you are in control. You are in control. This environment is horrible, and it's their fault that it's not yours. So if you're uncomfortable in church, you say, there's too much of this and not enough of this, and I need this. Or if you go to a movie theater and you can't, you start looking at things as, these are problems that I'm encountering, but it's not me. It's the environment, and I have to try to get around it.
I love that. Is that because I always like to have people leave with their final words of wisdom or inspiration? I mean, that sounds pretty inspiring to me, but do you have anything else you want to finish off with?
Just that the research shows you can have this great life. and that's all we need to do is just help them back to it.
Oh my gosh. Oh, well, that's all the time we have for today. Okay. That was so much fun. I just want to give you, Mary, a huge shout out and thank you for sharing your expertise and practical advice on visual deficits in hemianopia.
Yeah.
Your insights have been incredibly valuable, and I know our listeners will take away so much to apply in their practice. So I just want to thank you for being here and for that, all the important work you've done.
Yeah. Thank you. It was fun. I love this field and I love sharing the information. So
thank you so much. Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.